All right, welcome everyone to our webinar targeting tuberculosis, a clinical trials update. My name is Gal Tabachnik. I'm a program manager here at the Curry International Tuberculosis Center at UCSF. We're so glad you're here. And now it is my pleasure to pass it off to our medical director here at the Curry International Tuberculosis Center, Dr. Lisa Chen, who will be our moderator today.
Thank you, Gal. And I'm gonna, while I say, give a warm welcome to all of you. Good morning, good afternoon, wherever you are. I'll let our speaker, Bob, start to go ahead and load his slides up. So it really, I, I know Bob Horsberg doesn't need an introduction to most of you. We're just thrilled to have him join us once again. He's a professor of epi medicine and biostatistics at Boston University, and all of us know him as our clinical trials update guru, being part of many consortium for decades, and leadership roles with the union and the North American Union and Resist TB. So I promised him I wouldn't do a long intro, and I'll let him take it away if you can get your slides going there. And we will stop for questions in the middle. Just go ahead and throw them in chat, and I'll try to get to them as we go. Thanks for joining us, Bob. Hand it off to you.
Oh, thanks, Lisa, for the kind introduction. There we go. So first, I will say that I have no conflicts of interest to disclose. I am a participant in one of the studies that I will talk about. I'll mention that when we come to it, but it's not really a conflict of interest. So I'm going to cover a bunch of different things here, and I think the timing is propitious because the Union World Conference on Lung Health just completed, and there were some new data presented, and I will talk about those things as well. But I will divide this talk into trials for drug-sensitive TB, trials for MDR-TB, trials for pan-TB, and I'll go into what that is, and trials for latent TB. So I'll stop after each section to take questions because, as you'll see, there's a lot of material here, a lot of different drugs involved, and I think it'll be more efficient if we do questions at the end of each section. So starting off, we have some recent successes. These are trials I'm not going to talk about because they've been out for several years. WHO has approved them. This is the treatment, was called the SHINE trial for TB and drug-susceptible TB in children with less severe disease, in which a 4-month regimen instead of a 6-month regimen is given. And that was approved by WHO and came out several years ago. The second recent success is the 4-month trial of isoniazid, rifapentine, moxifloxacin, and PZA for drug-susceptible TB in adults, and that also came out about 3 years ago and is WHO approved. The third regimen that came out several years ago and is part of our standard now is the 6-month treatment of bedaquiline, protomidate, linezolid, and moxifloxacin for MDR-TB, and the first 3 drugs without moxifloxacin for XDR-TB. I will apologize for all of these acronyms and letters. In general, I'll try to spell them all out, but this slide went off the edge of the marker if you spelled out all those words, so I didn't, but I will try to do that. The other recent success was the 6-month treatment of levofloxacin for LTBI in contacts of people with MDR-TB, which came out 2 years ago. And so the last recent success I have shown here is really a question mark. And this is the 1-month treatment of isoniazid and rifapentine daily for latent TB, which has so far to date only been shown in one small and underpowered study. And we're hopeful that there will be a confirmatory study in the next few years. But right now, it's a small and underpowered result. So let's move now to the trials for drug-susceptible TB. Now, this is not an area with a lot of recent results. The WHO recommendation is the the standard regimen. The first one there, I guess my pointer here shows that's the standard regimen: 2 months of isoniazid rifampin, pyrazinamide, ethambutol, followed by 4 months of isoniazid rifampin, using fixed dose combinations when possible. That's the standard regimen. And then there's the regimen that I mentioned for children: 4 months in children who have don't have extensive disease. And then there is the regimen which was shown in the trial just several years ago. The middle one here is the 4-month regimen for adults, and the bottom one is the 2-month regimen for children. These are all the recommended regimens. I'm not going to go a little bit more into them. Now, one of the recent things that has come out has been that this regimen, the 4-month regimen for adults, was well tolerated in the clinical trial, but in clinical practice, it hasn't been as well tolerated. And here you can see the frequency of nausea and vomiting in 2 clinical cohorts on this regimen, one from San Francisco and one from New York City, showing a substantial amount of difficulty in tolerating the regimen. And in fact, it was discontinued in 32% and 23% of those who took it. And this is likely due to the fact that in a clinical trial, we carefully select the people that we know will be able to complete the treatment. But in fact, in real life, when you're in the clinic, you're treating a different set of population. They may be older, they may have a lot of comorbidities, and their tolerability of this regimen has been problematic. The other challenge with this regimen is that rifapentine is not available in many countries. And so this has made it difficult in Europe, for instance. There's not much access to rifapentine. So this regimen, although it's recommended and looked to be terrific in the sense that it gave us a 4-month regimen instead of a 6-month regimen, does have some serious problems. And so there are trials ongoing to try to come up with newer regimens that might be 4-month regimens that might be better tolerated. The next slide shows a listing of those, and you can see there's quite a few with wonderful names like Port and Orient and Radio TB and Smile TB. Some of the other names aren't so exciting, but I would point out that many of these regimens are variations on our standard isoniazid rifampin, pyrazinamide, and ethambutol regimen with higher doses of rifampin or higher doses of PZA, or both. And that, I think, is a red flag for us, because as I'll show later in the talk, higher doses of rifampin are not better tolerated than standard doses. And in fact, higher doses of PZA are considerably less well tolerated than standard doses of PZA. So I can't be optimistic that these trials, when we finally get results, are going to really move the field forward. The radio TB trial is one that has a potential to help us, because basically the idea here is that for minimal disease, you might not have to treat so long. And for extensive disease, you might want to treat longer. Or if it's not microbiologically confirmed, you might treat for a shorter period of time. These are practical things that I think would help us, but it's the standard regimen. It's not a new regimen. The NERT trial being done in India is a trial where you give 4 months of the standard isoniazid rifampin, pyrazinamide, ethambutol, and add to it moxifloxacin. The idea here being that you wouldn't need rifapentine, but this is a single-arm trial, so we'll have to see how that one comes out. And lastly, there is a trial of shortening of the rifapentine moxifloxacin regimen in children, just like the one of the standard regimen shortening in children. So some of these trials are enrolling, some of them are about to enroll. None of them are going to have results anytime soon. I would say 2 to 3 years minimum. So I don't think we're going to see a lot of activity in this space in the next couple of years, other than these trials moving forward to see what happens. There are also two phase 2 trials, and phase 2 trials won't lead us to a regimen. You need a phase 3 trial to get to a regimen that you can roll out. But the phase 2 trials might give us some ideas about how we could have better tolerated and shorter regimens for drug-susceptible TB. The two phase 2 drug-susceptible TB trials that are underway are CRUSH-TB, and this is with the Tuberculosis Trials Consortium, and STEP2C. The CRUSH-TB trial is a trial of a 17-week regimen that includes bedaquiline, moxifloxacin, pyrazinamide, and rifabutin or delaminid. So the rifabutin obviously would not be useful for MDR-TB, but for drug-susceptible TB, when isolates are susceptible to rifampicin, they're susceptible to rifabutin. And the delaminid arm, which would be useful for people that had rifampin resistance. This trial is fully enrolled. It's a small trial, 292 participants, but the idea here is they'll look at the results, which haven't come out yet, and then decide if they want to move forward with phase 3 trial. So this might give us a phase 3 trial coming up, and it'll depend a lot on the efficacy and tolerability of those two regimens. The STEP2C trial is a similar trial, which is looking at rifampin, isoniazid, pyrazinamide with a new drug, BTZ-043, which doesn't have a name. It only has a number at this point. But it's a trial that might also give us a regimen that would hopefully be a 4-month regimen for rifampicin susceptible TB. The results of that trial have not been published, and they'll be deciding, as with CRUSH-TB, whether they want to move forward into a phase 3 trial after they get those results. So that's really all I have to say about drug-susceptible TB trials. I think we'll see some activity in this space several years down the line. Nothing in the way of new results other than the challenges with tolerability for the 4-month regimen, which is called the Study 31 regimen. But I will stop here and take any questions about trials for drug-susceptible TB.
Well, I'll give people a chance to throw in a question if you have a moment. There is just one question. One of the other listeners did chime in with the answer, but I'll just throw it to you, Bob, as well. So for the prior slide, are all these regimens for drug-sensitive TB by DOT? So even though they're 4 months or 2 months, are they all still being conducted under directly observed therapy?
Not all, but most. I mean, the idea is when you're doing a phase 3 trial, you want to know if the regimen works. And afterwards, you need to do a trial to see how well it works if it's not given by DOT. So by and large, the trials are done with DOT, but I can't speak specifically to any of the individual trials that I've mentioned.
Yeah. All right. And then what drug family is BTZ-043?
Well, I can't remember the exact name. It is it's something that's similar to antipsychotic drugs. So it's a new family, and that means that you wouldn't expect to see resistance to it. But I can't actually remember the name of the class of drug. If I had time, I could look it up, but someone else may be able to put that in the chat for us.
Yeah, we can find it and post it. All right. Well, why don't we let you keep going? Because this is all interesting stuff. I do agree. I think a lot of the people here in the crowd have experienced exactly what you pointed out with the 4-month regimen. It's not easy for clinics to take on, and rifampicin has been really hard to get. So thanks for reiterating that, Bob. But
it's not a problem just in the US, as I said. It's a lot of places.
Great.
Okay, so let's move on to trials for MDR-TB. And as everybody probably knows, MDR-TB is TB with an isolate that's resistant to rifampin and isoniazid, although in some cases, particularly when the diagnosis is made with GeneXpert, the isoniazid susceptibility is not known, but we use the same regimens to treat these patients. So there are 3 recently completed trials of treatment of MDR-TB, phase 3 trials, and these are the NTB trial for fluoroquinolone susceptible disease, the NTBQ trial for fluoroquinolone resistant MDR, and the BEAT tuberculosis trial, which is an interesting trial done in South Africa in which they treated people who had MDR without a known fluoroquinolone resistance and then altered the regimen once they got the resistance back. So I'll go through these trials each in some detail. So this is the NTB trial. These are all 9-month regimens, and 750 people were randomized to one of 5 investigational arms and a standard control. Now, the standard control was whatever the program was using. And during the time of the NTB trial, the standard regimen became better and better as more and more bedaquiline was available and linezolid and added to the standard control. So we have a standard control arm that worked very well. 80.7% of the people had a successful outcome, which means a cure without a relapse. However, the 5 different regimens that they studied, which were all regimens that contained bedaquiline or delamanid or linezolid, levofloxacin or moxifloxacin, a bunch of different combinations, were at least as good as the standard control. But one particular regimen, this regimen here, number 2, which was bedaquiline, linezolid, moxifloxacin, and PZA, was particularly well tolerated and successful. And this one actually was superior to the standard control arm. It's also worth noting that regimen number 3 over here, delamanid, moxifloxacin, clofazimine, and PZA, did not include bedaquiline. So this actually provides us with a regimen that you could use with a good outcome if, in fact, you have resistance to bedaquiline, and unfortunately, we're beginning to see a fair bit of that. So this trial was very successful. It gave us several regimens that looked pretty good, but one which was superior and one which did not require delamanid. And this is the tolerability, and you can see the arm that was superior here had a small number of deaths and a small number of AEs. Not significantly different from the control, number 6, and regimen numbers 4 and 5 that didn't have bedaquiline also performed pretty well. No surprise to any of us that the most commonly stopped drugs were pyrazinamide, which is one that we've known for many decades is difficult to tolerate, and linezolid, which we know from the experience with BPAL, is that many people can't take linezolid for the full 6 months, but in fact, they don't need to take it for the full 6 months. We often get a pretty good response as long as they take it for as long as they can. Remember that these regimens are all 9-month regimens and not 6-month regimens. So, so that's the NTB trial. Now, the NTBQ trial was an interesting one, again, because these are all people with fluoroquinolone resistance. It basically was an attempt to treat people without a fluoroquinolone, and the regimen used was bedaquiline plus clofazimine plus delamanid plus linezolid for 6 months in people with limited disease and for 9 months in people with extensive disease. And there was an option to extend treatment from 6 to 9 months if the response at 6 months, if they were randomized, if they were in the 6 month, they had limited disease, but the response wasn't satisfactory. And the results, which were presented here at the union meeting just a couple of weeks ago, show that overall, in the modified intention to treat group, this was a non-inferior to the control, but we saw a substantial difference in that the people with limited disease did pretty well, but the people with extensive disease, the control actually appeared to do better. So what this means is that we have a sort of a mixed outcome in the sense that the people with limited disease, the regimen seemed to work pretty well, but those with extensive disease, it didn't work so well. And these are the adverse events, and you can see that the control actually had more adverse events than the experimental arm. There was, however, a death imbalance in that the experimental arm had more deaths than the control arm. And this was probably related to the fact that the people with extensive disease on the NTBQ regimen did not do so well. So the takeaways from this study were that the regimen, which is called BCDL, bedaquiline, clofazimine, delamanid, and linezolid, for 6 or 9 months, produced high rates of good outcomes, but slightly lower than the standard long regimen, which was the control regimen. And that if it was extended to 9 months because of a delayed response, it still seemed to do pretty well. But in people with severe disease, even the 9-month regimen was not sufficient to prevent relapse compared to the long regimen. So again, it does give us an option to BPAL for people with XDR-TB, but it will probably need to be given for longer than 9 months in people who have severe extensive disease. Moving now to the Beat Tuberculosis trial. As I mentioned, this was a trial, a very practical trial, because you often don't know the fluoroquinolone susceptibility. You only know that the patient has rifampicin-resistant TB. And so in this one, they gave a 5-drug regimen: bedaquiline, clofazimine, delamanid, linezolid, and levofloxacin. And then when they got the susceptibility, either by a rapid test or by phenotypic testing, they would discontinue, if it was fluoroquinolone susceptible, they would discontinue the clofazimine, and if it was fluoroquinolone resistant, they would discontinue the levofloxacin, since it probably wasn't contributing much. So then you came back to a 4-drug regimen, which meant that, it would be more easily tolerated. And the results of the Beat Tuberculosis trial are here shown. They haven't been published, but they were presented at the WHO workshop, and they are available. And you can see that there was not a significant difference between the control arm and the experimental arm with regard to most of the outcomes. And in fact, with regard to adverse events, the interventional arm was actually a little better tolerated than the standard arm, which contained a lot of drugs like ethionamide and cycloserine, which we know aren't very well tolerated. So not a surprise, but a very helpful outcome and a very practical regimen that can be used in the field without great difficulty. And this led to a recommendation earlier this year, an updated regimen, updated recommendation for regimens for treatment of MDR-TB from the WHO. And what was there before is the 6-month bedaquiline, protamidine, linezolid, moxifloxacin regimen, and individualized longer regimens. But the 2 in blue are the ones that are from the NTB trial and the NTBQ trial and the Beat Tuberculosis trial. These 2 new recommendations for treatment: the 6-month regimen for MDR when fluoroquinolone resistance is unknown or resistant, and the 9-month all-oral regimen from the NTB trial for fluoroquinolone susceptible MDR-TB. The WHO did not make a recommendation for bedaquiline resistance, but as I say, we now have a clinical trial that demonstrated a regimen which is successful and better than control, or at least non-inferior to control, for people with bedaquiline resistance. So this is progress that I think is very useful. And so I don't expect those will be updated anytime soon. However, there are a number of trials, both phase 2 and phase 3 trials in the field for MDR-TB, and I will next go over these. Um, the PRISM trial is a trial for MDR-TB that's fluoroquinolone susceptible, and it's a stratified treatment, which is to say people with less extensive disease get shorter treatment, and people with more extensive disease get longer treatment. And the hope is that we can shorten the treatment for people with less extensive disease. That trial is just getting going, so it'll be a while before we have results there. The INSPIRE trial is a trial which is using 6 months of bedaquiline and delamanid and contazelid, which is instead of linezolid. So contazelid is another oxazolidinone, which we hope will have a better trial, a better tolerability set of signals. Has been studied in a phase 2 trial, appeared to be well tolerated, and so a trial is going forward to see if that will pan out as a replacement for the BPALM type of regimen, which has linezolid in it. And then lastly, a very interesting trial of 6 months of pseudopiorine, which is a new drug, and of the same class as bedaquiline, plus optimized background therapy. This trial is going on in China. It's optimized background therapy plus placebo versus optimized background therapy plus pseudopiorine. And this is just getting underway as well. So those are trials which will give us some answers, although not in the very near future. And then there are a few phase 2 trials, interesting ones. The one I'll mention here is this is the trial that we're doing, which is called the DRAMATIC trial. And this is a trial in which only one regimen is being given. It's 5 drugs, bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine for fluoroquinolone susceptible MDR-TB, and patients are randomized to one of 4 durations. So the idea here is that we'll see what's the shortest duration that gives an acceptable outcome, and this trial is really meant to demonstrate that this kind of a trial design will be useful in future trials for determining the shortest possible regimen. It's not really designed to demonstrate that this regimen is better than any other regimen, so there's no control arm, and it is a standard regimen of already acceptable drugs. So that's the landscape of MDR-TB trials, and I'll stop here and take any questions about MDR-TB trials.
Great. Thank you, Bob. Right off the bat, there are a couple of questions, but while other people are thinking of their questions, these newer trials that you just reviewed, is the comparison arm now BPALM? I mean, is that what is in the study designed? Kind of, because I know that it's now the standard regimen for many countries.
Yeah, it really
for MDR.
depends. It really depends. So, like in the PRISM trial, the comparator, I believe, is I mean, it's the standard regimen at different durations. So it's kind of like
Right.
dramatic in the sense you've got 2 different populations. You're looking to see if people with less susceptible disease or more susceptible disease can take different lengths of treatment. Some of the other trials, like for instance, the pseudopiorine trial, I presume that the quote optimized background therapy will be BPALM, but I actually don't know in China what they're using as the optimized background therapy. That's what it should be. So yes, standard therapy, I mean, the control arm in any of these studies is going to be some WHO-approved regimen. But you'll notice that there are 4 different WHO-approved regimens. And so most trials are allowing any of those. So it could be a long regimen, it could be a BPALM regimen. It is whatever is being used at the time.
All right. Well, I think there's someone hopeful out there. Anne Rickert is asking, is contazelid available in the US?
I don't know the answer to that. It is
Yeah, I
Contazolit is not the only oxazolid known. There's tedazolid and also sutazolid, one that's been around for a while, and these are all being studied. So there is hope that we can get away from linezolid and it in any one of those. And I think if any one of those does really pan out to be better, then it will become much more widely available. These are all being studied by the trial networks where I think there's a commitment to get the drugs out. They're not being studied by the companies.
Yeah, I think that's something for and you asked the question, but other people who are looking at this, our availability of all these drugs, it's very, very variable, right? Delaminid is only available through compassionate use, and cases that have needed it have graciously, been given the drug by Otsuka. It's a long process. Um, Clofazimine in these studies still can be very difficult for us to get. You have to go through many, many hoops. Andy, you should feel free to uh, unmute if you'd like, Andy, because you seem to have your finger on um, compounds from the TB Alliance. And I guess the question is, it, are is anything available for compassionate use that you know of? But
You're talking in the US.
in the US, yeah, Andy's writing also Depazolid. I'm gonna really butcher these names out loud. I can, and the novel oxazolidinone compound TBI 223 from the TB Alliance. So,
Right. There's a lot of activity in this space, but nothing ready for prime time. And when they still have numbers, that they haven't moved forward. At least Contazolit and Tedazolid have names because they are sold in other countries for treatment of staph infections, etc. But at this point, I don't think we have any good data on whether they're really better tolerated for 4 to 6 months at substantial doses than linezolid.
and I think my good colleague John Samowski is probably looking things up furiously, and he's also trying to help answer there. He's probably looked up Contazolit is not available in the US. All right. A lot of interesting stuff, a lot of things to think about here. But Bob, I'm going to let you keep going.
Okay, so we'll move on to our next set of regimens. Here it is. This is the Holy Grail, a regimen that will treat TB without the need for drug susceptibility testing, a so-called pan-TB regimen. So what this means is it doesn't contain any of the drugs that we're already using, to which we have lots of resistance. The idea would be that you would come up with 3 or even 4 new drugs, drugs for which we don't need to worry about whether there's drug resistance out there. I'm not going to go into, there's a big debate about whether this is a good idea or not, but it's definitely out there. And the reason it's out there is this slide here, which I won't go into, that this is the global new TB drug pipeline for 2025, and there are a lot of new drugs, including new classes. So we actually have the possibility of putting together a regimen of 3 drugs, none of which you would expect any resistance to. And if we can do this and bring this forward all at once, we might be able to accomplish what the HIV people accomplish, and that is combination therapy that doesn't rely on you knowing the drug susceptibility of the patient's isolate at the beginning. You can see in phase 2 now we have quite a long list of drugs, but some of them still have numbers, as you can see. So, this answers the question though of what BTZ is. I think it just says new chemical entities. So, but the point is that the drug pipeline, which was initiated through efforts about 25 years ago, has really begun to be productive, and many new classes of drugs are available. So I'm not going to go into that, but now I will talk about the trials that have come out, the pan-TB trials. And these are 2 trials. They're phase 2 trials. both of which were presented at the union meeting. The PAN-TB trial, this is the Gates Medical Research Institute trial, and they stole the name, so it's going to be now PAN-TB trial is a specific trial as opposed to a type of trial. And then the quantum TB trial by Otsuka. These are two trials. These are both phase 2 trials. And the idea here was to do a phase 2 trial and decide whether to move forward with a phase 3 trial. So I'll first talk about the GMRI trial, the PAN-TB trial that stole the name. And this one is bedaquiline, protominid, sutazolid, and a new drug, quabodepastat. The idea is and here the second regimen is the same regimen, but substituting delaminid for protominid. Because as Lisa mentioned, protominid and delaminid are not always equally available. Some countries can get one, some can get the other. And since the drugs are extremely similar, the Gates people thought it'd be worth doing these two. The idea is not to compare the two regimens, but rather to see if either of these regimens had a successful outcome over when given for 4 months. And then the idea would be to take the best arm into a phase 3 trial to decide, what's the right duration to give this regimen. And these are the data, the results. And you can see that sputum conversion at 2 and 3 months was not what they had hoped to see. Even at 3 months, 68, 67, 80% sputum culture conversion. So 80% was the control arm. So the investigational arms weren't that good. The DBQS and PBQS were not good enough to move forward. So the Gates folks have backed off, and they're now thinking about what else they could do to try to move this pathway forward. But this is a result that suggests that it's not going to be, this particular regimen is not going to be moved forward into a phase 3 trial. They also prevented their long-term results, and you can see that, in fact, the unfavorable outcomes at the end of treatment, which is with follow-up, which includes now relapse, neither regimen was good enough to want to move it forward into a phase 3 trial. So that is an unfortunate result, but this is why we do the studies. And so they're going to go back to the drawing board and try to come up with another regimen that might be effective for 3 or 4 months with good long-term outcomes. The next trial, the quantum TB trial, was a trial, and Otsuka did this trial, and it's a similar in design to the PAN-TB trial that I just talked about. This is quabodepastat, bedaquiline, and delaminid for 17 weeks versus isoniazid and rifampin. And it was given to drug-susceptible people just to be able to have a comparator. But unfortunately, this regimen did not, it had, over the 12 months follow-up, it had 12% relapses. The standard regimen had only 5% relapses. So similar to the folks at GMRI, the people at Otsuka are going back to the drawing board, thinking about adding another drug, possibly a quinolone for drug-susceptible TB. You would then have to, it might not, adding a quinolone might not get you a PAN-TB regimen because you would have to worry about fluoroquinolone resistance, but adding a fourth drug to try and strengthen this regimen so that a 17-week regimen might be acceptable. There are also quite a few other phase 2 trials underway. None of these have results, but these are using a lot of the new drugs, and it's very exciting. So the Decision trial is bedaquiline plus delaminid plus our friend BTZ. The RAD-TB trial is bedaquiline plus protominid plus sutazolid or TBI-223, which is another oxazolidinone. The NC009 trial, which is has an exciting new drug which has up until now been called TBAJ 876, but which is now called sorfequilin, which is like bedaquiline. And this would be sorfequilin plus protamidate plus linezolid. So similar to the BPAL regimen, but now with this new sorfequilin instead of bedaquiline. And that they did report the 2-month results, which look very promising, but that's all they have at this point is 2-month result. They reported that at the conference just 2 weeks ago. And then the Paradigm 4 TB trial is looking at a combination of ganfebrol, BTZ, quabodepostat, and delpazolid. I had to work hard to get those out of my mouth right. But this is 3 new classes of drug plus a better tolerated oxazolidinone. So now we're getting to the point of where we might have a regimen that really would have 3 new classes of drug and might really be a successful pan-TB regimen. At any rate, that's what we have out there. There are other trials that have been are on the drawing board, including another one with 3 new classes of drug called clobber-TB, but that one's still looking for funding. So these are the ones that are actually underway, and these are phase 2 trials. We might have answers in a year or two on some of these, and if they're promising, then hopefully they'll move forward into a phase 3 trial. But that's my summary of the pan-TB trials, and so I'll stop here and see if there are any questions. And I mean, I'm happy to take, if you have a question about drug-susceptible TB or others that you just thought of, I'm happy to take that as well.
Well, folks are thinking, Bob. Well, first of all, I'm still laughing at the name clobber-TB. I kind of like that one. But I'm very excited to see more, hopefully better tolerated linezolid substitutes moving along the pipeline. I think we really would love to see access, some definitive data and then access to a better tolerated drug there. But the name that keeps coming up that people seem to be excited about, and I notice is a theme throughout those trials that you just covered, is quabodepostat. And so when you think about the role different drugs play in terms of their bactericidal activity or their sterilizing activity, tell me what you know about quabodepostat.
Well, quabodepostat targets it targets a new metabolite of TB. It is, I believe, a target that requires replication, so it might not be a way to get at non-replicating organisms, but it's an important target. And ganfebrol and BTZ also have different targets. I'll be honest, though, my sense of this is that the targets that we really need to be working on are the electron transport chain targets, which bedaquiline targets, and so does there's a couple other drugs out there. So does clofazimine. So does I'm blocking on the name, but there's a couple of drugs, and if we can get several drugs that all target that same chain, and it's the electron transport chain, which is required by TB and doesn't overlap with the electron transport chains of humans. Then I think we might be able to have a really effective regimen. I'm not sure that just having 3 new drugs will be enough, but we'll see. I mean, we know that we have to treat for a long period of time in order to really get all the bacteria eliminated, and something that when you target the electron transport chain, you really stop replication quickly, and not all of these drugs are going to do that.
I'm not seeing any other questions popping up, so I'm going to let you keep going. Thanks, Bob.
All right, so now we'll move on to trials for LTBI, latent tuberculosis, basically usually defined as having a positive skin test or IGRA and no evidence of active disease. WHO currently recommends the 6 months of isoniazid, 6 to 9 months, 4 months of rifampin, 3 months of rifapentine plus isoniazid, and then for presumed MDR-TB, 6 months of levofloxacin. These are the recommended regimens. I'm not going to go over those trials. The recently completed trial, which I do want to talk about, is the 2R2 trial, and this is for drug susceptibility when the index case had a susceptible isolate. This trial was a trial that looked at increasing doses. We know that standard doses of rifampin for 4 months are effective. So this trial looked at shorter regimens of higher doses of rifampin, 2 months of 30 milligrams per kilogram, 2 months of 20 milligrams per kilogram, or 4 months of 10 milligrams per kilogram, which is the standard recommended dose. That was the control arm. But what they found was that the 2-month regimens had significantly worse completion than the 4-month regimen, and 2 months of 30 milligrams per kilogram also had worse safety. So this means that this is not going forward into a phase 3 trial. And it's also the reason that I'm skeptical about the future of higher doses of rifampicin for treatment, because again, you can see here that double and triple doses were not well tolerated. Now, it is certainly possible that our patients with TB are willing to tolerate things that our patients with LTBI are not, but that's kind of a sad state of affairs when you think that, in fact, this is not going to be easy to tolerate. So this for LTBI, this is the only result that we have, and this one was recently published. There are a number of trials in the field, however, and these are the phase 3 trials that are currently underway for LTBI. The asteroid trial that the TBTC is doing is giving 6 weeks of rifapentine for drug-susceptible LTBI, and they are about a third enrolled. You can see they've enrolled about 1,200 people. Their target is 3,600. So this would give us a 1.5-month regimen, which would be nice. The Phoenix regimen, the Phoenix trial, is a trial for patients who are household contacts of people with MDR-TB, and do not have active disease but have a positive skin test, and it's they're getting 6 months of delaminid. The trial is fully enrolled, although I'm pretty sure that they shrunk the sample size because I know they had difficulty, but they have closed enrollments and now in the follow-up period. So we might have some information about the efficacy of 6 months of delaminid for LTBI, particularly when you're concerned about drug resistance, and that would be a real advance. There's a new trial under development looking at bedaquiline for LTBI, and this could be quite promising because, as many of you may be aware, bedaquiline has a very long half-life, and so giving it for a short period of time could be very effective for a LTBI, and you wouldn't have to give repeated doses. There's also efforts to develop an injectable formulation, but that's not at this point, I don't think, part of the development plan for that trial. So the last trial that I want to mention is the regimen of 1 month of isoniazid and rifapentine for LTBI, which looked promising in Africa but was underpowered. However, even though the WHO endorsed it, it will be good to see those results. I was hoping to see those at the union meeting, but they didn't. It didn't apparently get submitted. So there's nothing there on that line. So I am going to actually do a section on new directions in TB trials, but I'll just stop here. Any questions about the LTBI landscape?
There's a few here. What's the dose and frequency of rifapentine used in the asteroid trial?
I don't have that on my fingertips. It's
right.
certainly knowable.
600 milligrams.
Okay. Thank you, Tim.
Tim
Okay.
Sterling, thank you for unmuting.
Thank you for that.
you. And then there is an important question. Is there any concern for antibiotic stewardship for using bedaquiline for LTBI? I think we're all becoming more and more aware of the bedaquiline resistance out there, just the natural occurring mutations, and just the concern for losing the drug. Using it for LTBI, are there
I think that's an important
discussions?
concern, and I'm hopeful that the Breach TB team that's working on this trial design I'm sure in the trial they'll very rigorously exclude anybody that might have disease, but and obviously they'll follow people and see if any resistance occurs. I think that the question really relates to, well, if that trial works and we roll this out, is that going to lead to a lot of bedaquiline resistance? And that is a concern. It was a concern with isoniazid treatment trials for LTBI, although in fact, there's no evidence that isoniazid treatment of LTBI has ever led to the emergence of isoniazid resistance. So it's a concern. It's an important question, and I don't know. It certainly raises issues about antibiotic resistance.
Yeah, we'll all be watching. And I think Abby Geltmeyer brings up an important issue that we're having more and more discussions about. Are any of these trials designed to include children or pregnant women?
That's a question that is always a challenge. When there are data for the pharmacokinetics of the drugs being used, children are usually involved quite quickly. The challenge has been, of course, particularly with new drugs, children are rarely involved because of that issue. Pregnant women are usually kept in, if a pregnancy occurs while someone is in this trial, most of the trials now are offering the participants the chance to stay in the trial with the agreement to be followed, so we can get information about whether those exposures pose any risks. But enrolling pregnant women at the beginning is generally not allowed. So things are moving very slowly in the right direction. The real challenge is knowing what the dose is for including young children.
And there's a question of, what's the opinion? So this goes back to drug-sensitive TB of, and I think you had some of the phase 3 trials that were using the high dose rifampin for drug-sensitive TB. The question is about, hearing that experts we have for many years been saying we've probably been underdosing rifampin. And so now these trials are using the higher doses. You've kind of inferred your thoughts about the use of higher doses, but I think people just want some clarification there.
Right.
So
there's no
the
question
rationale.
that the underdosing is true in the sense that, yes, higher doses are more efficacious, but it doesn't mean that they're better tolerated. And, a number of us in the field feel that the tolerability aspect has been kind of buried in the rush to get to faster regimens, to shorter regimens. I'm going to talk about that actually in my next section. So I'll address that coming forward. But it is true. I mean, in a sense, rifampicin was underdosed in the sense that higher doses work better, but that doesn't mean that higher doses are going to lead to a better regimen.
And just for clarification for Brianna here, we are talking about adults higher than the 10 milligram per kilogram standard dose. But she also asked, is there anything being done for higher doses in children?
Not to my knowledge. I don't think any of those trials are enrolling children, but I can't speak. I don't actually know them in great detail.
Okay. All right. Well, I'll let you keep going. And if I missed any questions, please just repost them so they show up now at the end. I think there was a lot of discussion back and forth there because we'll have a little bit of time at the very end as well.
Sure.
Thanks.
Okay, so I'm now going to talk about new directions in TB trials, and I'm going to review some data. This is our standard regimen: isoniazid, rifampin, pyrazinamide, and ethambutol. This is a prospective cohort in which they carefully looked to see how well the drugs were tolerated. And you can see they weren't well tolerated at all. There was a 68% of the people had a grade 2 AE or higher, and 10% changed therapy due to adverse events that were related to the drugs. Some of these, like anorexia and fatigue, are a little hard to document, but I think we all know that it's difficult to keep people on the standard regimen. So when one says that the any new regimen is as good as the control arm, which is this standard regimen, that's not actually very good. And here's some more data in large retrospective cohorts, and you can see a lot of treatment interruptions due to adverse events associated with changes in treatment, prolonged treatment, and lower treatment success. So I'm working with several other people to try to move forward the idea of getting regimens that are not necessarily shorter, but are better tolerated. And this is my concern about the high-dose rifampin regimens, is that they may work better, but if they're not well tolerated and people don't take them, then that's not really going to help us. So if we were to refocus on the patient experience, in other words, how easy is it for the patient to complete the regimen? It may be that a 6-month regimen would be preferred by the patients because if it was better tolerated. Now, our current 6-month regimen, I'm not sure is, but maybe some of the new drugs will be better tolerated. So instead of pushing and pushing to get to the shortest possible regimen, let's look for one that minimizes the adverse events, that studies the kind of people that we're treating, which includes people with comorbidities on other medications, older people, people who use drugs and drink alcohol. We need regimens that work for those people. And our primary endpoint, I would propose, would be on-time treatment completion of the original regimen. That's the regimen I want to see. It doesn't necessarily have to be a 2 or 3 month regimen. It just has to be one that people can get through without interfering with their lives. And if you talk to the patients, they will tell you that what we currently give them isn't that easy to take. So the kinds of trials that we're trying to move forward to are things like giving ondansetron to prophylax, to decrease nausea, which is really common, to substitute fluoroquinolones for isoniazid or pyrazinamide, particularly pyrazinamide, because we know that's a bad actor. It's also possible that people with less extensive disease could have a 6-month regimen without PZA. That's not out beyond the pale here. People who have lymph node disease probably don't need all these drugs, and yet we treat them as if they did. Another thing, there's a lot of the adverse events that patients get are in the first 4 to 6 weeks of treatment. And one of the biggest problems seems to be the fact that we hit them with 4 drugs at once. There have been several small trials that indicate that if you start the drug, every couple of days a new drug, and so that by the end of 2 weeks they're on 4 drugs, you don't increase drug resistance and you make it easier for people to tolerate them. So that's another strategy that we think needs to be looked at. And lastly, there are a number of things out there that are putatively hepatoprotective. So that is to say, if you gave them along with the treatment, you could reduce the risk of hepatotoxicity, which is the biggest and most serious toxicity, although it's not the one that leads people to not complete treatment as often. It's things like nausea and poor sleeping and loss of appetite that are probably the biggest things that lead people to stop treatment and stop coming back to our clinic. So those are the kind of things that we'd like to see studied more, and some potential ways to study them. So in conclusion, we've made real progress in the last decade, especially with MDR-TB. Shorter is definitely better, but only if it's also better tolerated. And certainly the MDR-TB regimens, the BPOM regimen is much shorter than we had before and much better tolerated. So that's a real success. There are many new drugs in the pipeline, but so far, we really don't have a good handle on the safety and tolerability. We've seen phase 2 studies, and we know that they didn't show any bad signs in a phase 2 study, but phase 2 studies are quite small, and they really are not a good indicator of how things are going to do in a phase 3 trial. The PAMZ trial, which I didn't talk about, it was a failed trial from several years back, is a good example of that. It looked terrific in phase 2, and when it went to phase 3, it really failed. It was extremely toxic. So I'm somewhat pessimistic about ever getting a pan-TB regimen, although it's possible, and we have a window of opportunity here. If we have 3 new drugs that play well together and are all well tolerated, we might have it, and that would be wonderful. But I have optimism that we can do better than our current standard regimen. So those are my conclusions, and I'm happy to hear any other conclusions or further questions.
Well, I love ending with an optimistic note because, but I want to say what I'm really optimistic about is hearing kind of real thought leaders like yourself, Bob, in this clinical trials area really push forward this messaging of we need better tolerated. We'd love shorter regimens, but we also would love better tolerated regimens. I think people in the field have felt this all along. And that folks like you, Bill Berman has stood up in several conferences lately, also really pushing that we need to put this into our trial design, really put that information out there, make it clear in terms of side effects, because what you see truly in the field is very different than what happens in clinical trials. And we see people getting sick all the time. And I think Randall Reeves, you're out there. This is something I know you've said a lot too. His comment was discarding a new regimen like a pan-TB regimen because it does not perform well in 17 weeks might mean ignoring safer and better regimens at 24 weeks, right? And I think that's exactly what you're saying. Yep. Randall, I know you've been a big proponent here as well. Don Nierenberg Reynolds mentions GI intolerances and other adverse events. What is the history of other avenues or routes of administration? So could we do better if we did something other than oral routes? Any thoughts there, Bob?
That's actually an area of intensive study right now, and that is long-acting injectable TB treatment. It's not ready for prime time, but there's a lot of work going on with drugs that I mean, obviously you have to have drugs that work well together, have similar pharmacokinetic capacity, but giving them the way we give HIV drugs, injectable for 6 months, might be a terrific response, but we're not there yet. So the idea is a good one, and people are working vigorously on this, but we don't have any products yet.
Well, somewhere a little adjacent to this is Marguerite Leeds adds, in terms of tolerability, her patients struggle most with the time commitment. And she wishes for extended release depot injections or implantable treatment.
Yeah, no, I mean that has many advantages, but we don't have it yet. I think, I mean, what I think is more close to being able to be realized would be once a day, 1 pill regimen that was easily tolerated, like we have for HIV. If 3 of the new drugs worked well and you could put them in a single pill and take once a day, then the time commitment would be much less because it would be just a single pill a day and you wouldn't have to worry about side effects. But I agree. I mean, an injectable regimen, I mean, something with long half-life that you could be, yeah, that'd be great because patients wouldn't have to worry about it. But it'd have to be very free of side effects because once you inject it, it's hard to get it back.
Yeah. There was an older question that I didn't get to before, but it was just another question on the asteroid trial. Is the rifapentine being dosed weekly or daily? It's a daily dose, right?
Daily, yeah.
Daily dose. Yeah, thank you. And yeah, and Randall's adding rifapentine is likely to be both safer and better tolerated than RIF in standard treatment. We still don't know that.
Right.
So we don't know. Yeah.
Until we get it available and get it out there, and use it. I mean, we know that it's not well tolerated. That the regimen, including rifapentine, is not well tolerated. We don't know that it's the rifapentine that's making it hard to tolerate. It could be the moxifloxacin. So we have to sort that out.
Yeah. And then we're getting a voice out for, once daily dosing sounds great. And also Lisa Polly's adding there that we really do need the pediatric suspensions that are available elsewhere, but not available here. You were naming combination treatments. There are combination pill formulations overseas that we don't have available as well that could make many of our regimens more tolerable just from pill burden alone.
Mhm.
So sad but true, things are out there, but not necessarily out there for us yet. So we'll keep making noise, everyone. That's the thing.
Good.
Any other questions, or anyone would you like to unmute? I mean, we've got folks like Tim Sterling, Andy Vernon on, people very involved in this area. If you'd like any closing comments as well, along with Bob, we'd be happy to have you unmute. You're getting a lot of thank yous too, Bob, in the chat.
I'm just repeating the things that our people are talking about, and I'm happy that the people are talking about improving tolerability. I will say one of the advantages to studying tolerability is we don't do nearly as good a job as we do with efficacy, so it means you don't need such big studies.
I always wonder, I think that there's so many best practices known in other fields, like the care of nausea, right? Our friends in oncology are so good at this. They've got it down to a science. Why haven't we been able to apply it in our clinical care?
Yeah, the oncology people are much better at preventing nausea than we are.
Yeah, yeah. Well, I think well done. You're getting a lot of love. So happy all of you joined us. It really is, Bob. Everyone can't get to conferences like Copenhagen. So what you've been able to bring here is really, really a bonus to our TV community. So hope you'll keep doing this for us.
I hope I caught everything because it was very difficult to go to all those sessions. Oh, it looks like Andy has a comment.
Oh, Andy, yay!
Yeah, thank you very much, Bob. This was terrific. I have a comment and a question. The comment is just about the growing presence of China in this domain, and the fact that you've cited both one of their drugs and a couple of their trials. There are some very capable and talented investigators beginning to enter the field. So I'm hopeful that we will see some very useful findings coming out of China. We're, of course, challenged in our efforts to collaborate there, and I hope that will help some of this turnaround. My question has to do with the use of anti-nausea agents. I followed Bill Berman's publications about tolerability and know that you're associated with that group that's working on this issue. With regard to the anti-nausea success of the oncologists, they by and large employ a set of agents, all of which have substantial interactions with rifampin and other rifamycins. So I'm interested in whether you're aware of any experience with those agents in the context of TB treatment, and what has been the result of the substantial drug-drug interaction with rifamycins.
Yeah, Andy, I'm not aware that it's been studied, and I think it would probably be necessary to use rifabutin or some other rifamycin if you were to study that. You're quite right that in particular the agents that are most commonly used are probably not available for us, but they've they have a long experience of looking into this. So I don't. It would be very helpful too if we could identify risk factors for who's likely to get nausea, because then we could tailor things a little more rather than just giving it to everybody, which would be difficult. I mean, I think we would have to alter the TB treatment in such a way that it was compatible with the anti-nausea agent.
The other issue in this regard that has continued to puzzle me is the fact that there are such different tolerability experiences in low and middle income countries as opposed to high income settings. And this has been true with the rifamycin hypersensitivity syndrome, and it's true with a lot of the other toxicities that have been problematic, probably with the exception, at least, of hepatotoxicity, which seems to be universal, although its frequency is different according to, in part, the distribution of acetylator variabilities.
I mean, I think we just don't do. Not everybody does the same quality of investigation about whether people are tolerating it. When people leave, when people disappear from treatment, you don't know why they did it, but I'm highly suspicious that they did it because they felt better not taking the drugs than they did taking the drugs, and that is an indication that perhaps the drug was causing some side effect that might not have been one that we would have picked up by grilling them about whether they had nausea or vomiting.
Well, I guess I'd want to throw a pitch in there as we're talking about what really optimizes a regimen. And not to put aside, I always think food ought to be in a regimen, but on top of the best care practice, a lot of this depends on having really optimal kind of case management capability. And as we're losing more and more of our public health resources, what we really got to fight for is, along with good drugs, good food, is the ability for that outreach to happen, to optimize that care. So, why people drop out? Well, a good case manager knows. So, we've got to support our nursing cadre and the, maintaining our nursing workforce in all of our clinics, because that's part of the structure. That's what makes this stuff happen. Well, thank you. Thank you, Andy, for jumping in the end. Always love to hear from you. Bob, I truly mean it. I hope you do this again for us.
My
and thank
pleasure.
you all for joining us.
Thank you, everyone.
Thank you again, Lisa and Bob, and couldn't agree with you more about case management.
All right. See you next time, folks.